Hello, everyone. I'm presenting my project tonight, which is my graduate project, Utilization of Simulation for Early Detection of Sepsis. When we look at the description of my project sought to incorporate simulation use as a means of educating nurses and allowing facilitation of learning. Simulation has evolved over the years from its initial use with pilots who are able to use simulations for more dangerous tasks of learning skills such as flying blindly. When we look at the progression into healthcare, it introduced things such as Rescue Annie in the 1960s, all the way up to our first Sim Man, who was created in 2000. Simulation has been used in healthcare to improve the skills of healthcare workers in performing such skills as CPR, working in teams, and in the particular task of delivering anesthesia. Sepsis, while a well-known condition, continues to go undetected with serious mortality consequences, with up to 1,000 people impacted per 100,000 people with severe sepsis. Nurses are considered vital to detecting sepsis early, but nurses must be educated on the early signs and symptoms of sepsis, risk factors, and organized methods for detection. In my particular graduate project, I created a scenario in which the patient was named Thelma Rogers. She actually met the SIRS criteria, and in addition to having pneumonia, which would be her infection, she actually met sepsis criteria. A simulation was created based on a patient that was septic, yet not in severe sepsis or septic shock. And then the simulation included objectives, background on the patient, her vital signs, her system assessment findings, lab values, chest x-ray with radiology report, and teaching points. I served as the voice of the patient and the doctor throughout the simulation and led the debriefing for the simulation as well. Both a pre and post survey were completed by the learners. When we look at the project learning objectives, we wanted the learners to initiate the nursing process through interviewing and completion of a focused physical assessment. We wanted them to analyze the data collected, evaluate laboratory values, and deduct correlation to the assessment findings. Prioritize and organize data to effectively communicate to members of the healthcare team through utilization of SBAR, which is the use of situation, background assessment, and recommendations when speaking to not only each other but also the provider or doctor. Identify signs and symptoms of sepsis and illustrate knowledge of appropriate action through nursing interventions implemented. And then finally, we wanted the learners to function as a team and be a good team member to collaborate, care, and advocate to meet the needs of the patient. When we look at the teaching points that were included within the simulation, the teaching points actually spoke to things such as code sepsis, which is a code that was used at this particular hospital where these new nurses were employed. When we look at the code sepsis, it actually set out the protocol, and it also gave them an indication of that SIRS criteria and how it could then progress to sepsis. So a lot of the education and the teaching points, and these were brought out during the debriefing session of the simulation, focus on that progression. So the SIRS criteria, where you would have a patient with a temperature greater than 101.3, a heart rate greater than 90, respiratory rate greater than 20, and then that white count greater than 12,000. The teaching points also then went on to the progression to sepsis, which is typically meeting at least the SIRS criteria and then a source of infection. In this particular project and simulation, again, her source of infection was the fact that she had pneumonia. When we look at how a person progresses from sepsis to severe sepsis, we're looking at the inclusion of sepsis plus organ function, lactic acidosis, or having significantly decreased urinary output, excuse me, abrupt change in mental status. There could also be a decrease in platelet count, difficulty breathing. And then we introduce terms like multiple organ dysfunction syndrome, or MODS, in which typically you have a person who has progressed to severe sepsis and now is experiencing 2 or more organs with dysfunction. And then, of course, there's septic shock, in which we see severe sepsis with hypotension. And it's not just the presence of hypotension, it is the presence of hypotension that does not respond to fluid resuscitation. All of those were areas that were then discussed in greater detail during the debriefing. When we looked at the facility, this particular graduate project was held at the Carolina Simulation Center. It was held for a group of nurses who were in the advanced program, which is a nurse residency program, and the target population were these advanced nurses who were actually new nurses transitioning into practice on their prospective med-surg emergency department or perioperative units. Just to touch on the Carolina Simulation Center a little bit more, it is actually a duly accredited facility, accredited by both the American College of Surgeons as a Level 1 Education Institute and the Society for Simulation in Healthcare as well. So it does carry that dual accreditation. The Simulation Center, while it is the Carolina Simulation Center and it does share housing with the nursing school there, it actually does do work outside of this particular hospital system and does numerous work within the community. They have a mobile simulation unit, and they have the ability to take mannequins out into the community and also facilitate additional learning opportunities. When we look at the advanced nurse residency program, it is a program that is offered by Carolina's Medical Center for new nurses who are again transitioning to the areas of medical surgical, the emergency department, and perioperative. When we look at the advanced program as a whole, it is actually a 10-month program that offers 36 hours of professional core curriculum and 12 hours of built-in simulation. It has formal classes and a preceptor training component. When we look at these actual new nurses and these roles in the very crucial areas of med-surg units, emergency departments, and perioperative, it actually ties in succinctly into looking at early detection for sepsis. We know that a person who's had a surgery is at risk for developing an infection. Again, if they meet that SIRS criteria, it's now sepsis. So these medical surgical nurses are vital to being that first line identification tool of seeing if these new surgery patients are actually becoming septic. And again, that's identifying the sepsis before it becomes severe sepsis. When we look at the emergency department new nurses, again, a lot of time they're ground zero for the patients who are coming in. And sometimes, again, it's not until it's severe sepsis or septic shock that in the emergency department, that a patient may get a second look. But again, now knowing that the real true goal is to identify sepsis as early as possible, which is again right at meeting the two SIRS criteria plus infection, the emergency department is crucial in also getting the institution and implementation of some of these sepsis bundles that have been advised by the Surviving Sepsis Campaign of 2012, where again the focus is not just early identification, but actually early intervention as well. In the emergency department, a lot of times that may be the collection of blood cultures so that we can get, again, that early identification of what bacteria is causing this issue. And of course, with perioperative nurses, their role technically is, again, understanding that they play a vital role in maintaining good hygiene and good aseptic technique, sterile if need be, and the prevention of patients becoming septic. So again, it was a really good focus for recognizing and moving away from what for this program used to be a septic shock simulation to what we created, which was then a focus on early septic shock and early sepsis identification as opposed to septic shock. When we look at the background involved research on not just sepsis, but also the utilization of simulation to foster education. When we look at sepsis, again, it's not a new issue, but sepsis remains one that while we have a lot of knowledge of it, again, we typically identify it way too late. Sepsis mortality rates can be as high as 15 to 30%, and that almost doubles, literally does double and increase to 30 to 60% once it's severe sepsis. nurses. As we get to things like MODS and septic shock, you can imagine that their mortality rates become even higher. The identification and creation of a process for early identification has been associated with the improvements in mortality rates. Again, when we look at some of the studies that look at the inclusion of simulation for education for practicing nurses, we have found that the research supports that simulation improves confidence, enhances teamwork, and improves communication among the healthcare workers. Again, simulation has been received a big surge and a push for being used in team training. And we see that it's not just a confident booster for the individual learner, but we found that instituting things like the team simulation also causes there to be a foster increased confidence in their team members. And when we look at more studies, we notice that when you look at the simulation, it's also been used to address emergency situations. And being able to enter an emergency scenario from a simulation standpoint, research has found that not only are the learners reporting that the simulation was favorable, but is having a positive impact on the educators as well, who are of course seeking ways to provide learning opportunities that are impactful for nurses who are interacting with patients. When we look at the process or method, again, I created a simulation, and this was a new simulation covering an old topic of sepsis, but again, without a focus on septic shock and more of a focus on early sepsis identification. I did create a pre and post survey that was administered to the learners before the simulation and then after the debriefing on sepsis. The simulation was conducted and a debriefing facilitated immediately thereafter. And then the survey results were then analyzed. When we look at the individuals involved in this particular project, the timeline and permission, individuals outside of myself did include my preceptor, who was there throughout the simulation to provide support. Of course, she was an integral part in discussing simulation for me to develop and create and then facilitate during my preceptorship. Again, Shirley knew of the septic shock scenario, but again, that really didn't meet the criteria of a learning gap for us, as nurses typically can identify septic shock. But again, research through my literature review of literature, did indicate that really the issue is identifying sepsis when it's early on. I did have a medical technologist that worked with me throughout the simulation when it was actually facilitated. Typically, the medical technologists operate the SimMan 3G, manipulating vital signs, body functions, and then also pulling up on the screen those various labs and diagnostic tests for the learners as I interacted with them as the doctor. Of course, I cannot leave out my learners who are active and passive part of this particular part of the simulation, as we had active learners within the simulation and passive learners sitting in the room outside of the simulation room watching a live streaming of the simulation. The timeline was approximately 15 minutes for hands-on mannequin nurse intervention, with, again, the bulk of the rest of their simulation experience coming in the debriefing, which lasted about an additional hour. And then I did not require any additional permissions for this particular project, as it wasn't a new introduction. We weren't doing any active experiments. Again, I had the opportunity to actually just create a brand new scenario for an already pre-existing program, which again, the topic of sepsis had already been identified as one to go over with the advanced learners. Again, these are new nurses transitioning to the practice in the various locations. But again, it was really the early sepsis identification that was identified as what needed to be created, and which that is what I created for this program. When we look at the evaluation, starting with the pre-survey, and again, this is actually a pre-survey and a post-survey question. This is one of the questions that actually focus on, can these learners, prior to the simulation identify what SIRS is. In this particular example, you see we have an 18, 25, 58, and 70-year-old with various conditions going on, but we're really looking at their vital signs to see if the learners could identify who actually met the SIRS criteria. In this particular example, it is actually B, the 25-year-old male with the indwelling catheter, heart rate of 95, respirations of 24, and tip of 100.6, who meets the criteria. When we look at Thelma Rogers, who was the patient in the simulation scenario, it was actually set up so that she met all of the SIRS criteria with a pulse of 98, respirations of 24, temperature of 101.6, and a white count of 13.5. This question, again, was presented in both the pre and post survey to see if students could, learners could identify the SIRS criteria, which is, of course, the foundation for the identification of sepsis. As a group, the learners felt that Ms. Rogers was only moderately sick in evaluating the simulation. And again, this was both the active and the passive learners. As a group with a scale of 1 to 10, identifying how sick Ms. Rogers was, as a group, they felt that at the highest she was maybe a 5. And again, this was prior to the discussion and the debriefing, just discussing the things that occurred during the simulation. When we look at the outcome, this is actually the pre-survey results, if you can see. Again, the 25-year-old male is actually the one who had and met the SIRS criteria. And you can see in the pre-survey, actually, none of the 8 learners identified that as SIRS. When we look at it during the simulation, the learners were able to identify that the patient had pneumonia, but they actually never made the connection to the fact that the patient was septic. During the debriefing, learners were able to discuss what they did well, and that was the passive learners as well as the active learners. It was learned that the nurses, again, were able to identify septic shock, but were less prepared to identify the signs and symptoms of early sepsis. Also, we found out that this group of learners were not aware of the code sepsis that was utilized within their various facilities. We were able to, at that time, pass out little badge cards that actually kind of gave them a little sheet of information on what code sepsis was, and again, that SIRS criteria and how to meet that SIRS criteria so that they can kind of keep it present in their mind what meets the SIRS then with an infection present sepsis criteria, which the learners felt was quite helpful. Debriefing highlighted objectives that were met, and learning conversation was then facilitated regarding SIRS, sepsis, severe sepsis, multi-organ dysfunction syndrome, and septic shock. Again, if we look at things like SIRS, one of the things that we were able to discuss in the debriefing is, again, it's that mentality coming from nursing school of looking for signs and symptoms outside of the norm. If we look at 2 of the SIRS criteria, it's greater than 90, which again, that's less than 100, which again is a new nurse that may not be a red flag to you. Or again, when we look at some of these elderly patients who may not ever get that super high temperature, if you're looking for the temperature to go up as your only identification of a person being septic, again, we were able to talk about these things and these nuances and differences that you may not see or may not come to the mind of a new nurse. When we look at the post survey, you can see we had some success here. So again, they received the same question. And again, although not 100%, we can see that 3 of the 8 learners did now correctly identify that the 25-year-old with a heart rate of 96, respirations of 22 does meet the SIRS criteria. While not reflected in the complete ability to answer this question correctly, you'll see in the slides to come that overwhelmingly the students did feel like they had learned quite a deal about sepsis, and again, what their facility had in place for identification of sepsis. So when we look at how did it go, overall very favorable. When we look at things like how they felt they did in recognizing signs and symptoms, and this is post-survey results. Again, 75% strongly agreed that they felt like they were better able to recognize sepsis. And when we look at if they felt more confident within their role as a their role within a patient care team, we can see that that result went up to 87.5%, felt more confident in their role within being a team member, which is, again, something we wanted to see with this project. We wanted to be able to provide needed information and education on sepsis, and also have the learners walk away from the experience feeling empowered and not defeated. Um, just to touch on that, there were a couple barriers in the process. Again, we do not have control within the simulation center over the advanced schedule. We don't always receive information on which learners are arriving to this session for simulation. The timing of simulation is not always optimal for the learner, and some learners actually come to the simulation experience with previously poor experiences during nursing school. A couple of things, I felt like the nurse educators, or the simulation educators, did an excellent job of adjusting to these barriers, and again, were able to help bring me in to be a part of the process for addressing some of these issues. At the simulation center, they are very flexible in the scheduling. It is a lot of time constraints, and they just kind of get it all addressed and make sure that each learner gets the simulation facilitated that's needed and tasked for that particular group. Again, it would be nice if we knew what mixture of learners were coming. Again, it would allow, as an educator, for us to provide a better experience, and one that was more tailored to what they may see on their unit. And speaking to the timing of the simulation not being optimal, again, some learners were able to come on a day off, but most learners came after working a shift. So again, for educational purposes, some of them were kind of already a little spent. But again, what I found was that orientation process that the simulation center leads actually allowed for them to kind of come into the simulation understanding it's going to be a learning experience, but a fun learning experience where they would not be judged and where they were free to discuss and ask questions. And when we look at the previously poor experience in simulation, this is actually something that does come out during the orientation process. There is a process for advanced where the learners will come in, and this is without any hands-on simulation, to just get a feel for the layout of the simulation center. They get a tour of the simulation center, what room they're going to have their future simulations located in, and they're also able to openly speak about any previous experience that they've had with simulation. As these are new nurses, most of them have had experience with high fidelity mannequin use in their prospective nursing education programs. However, some of the negative feedback that we received is that they felt more criticized because they had to review the video footage of themselves, and they felt like the opportunity was taken to just point out everything they did wrong. I was able to be a part of the education staff in letting these learners know that for the simulation center, they're big advocates on psychological safety in simulation use, with an understanding that the focus is not on critiquing or criticizing, but again, fostering an environment where it's safe for them to learn, it's safe for them to make mistakes and then learn from those mistakes. Again, they take their time doing orientation to explain the importance of the psychological safety, to let them know, again, they're not students, they are still learners, but it is, again, a focus on them learning, and again, not punitive because there's not a grade associated with it. When we look at the project alignment with outcomes, it is felt like this project does align with the outcomes of this graduate program. I did complete an extensive review of literature, again, for this particular project, not only on simulation, but sepsis as well, in the creation of a simulation that would speak to sepsis, with the utilization of simulation to foster that education. There are resources with the Mayo Foundation, as well well as the Institute of General Medical Sciences, that all provided a foundation of information on sepsis. Data was collected on both the prevalence of sepsis and simulation utilization for the education of nursing professionals. Again, that's not just nursing students. I was able to take the lead on the revision and creation of a new simulation for the purpose of educating new nurses, acting as both the lead during the simulation, conducting not only the simulation, but the debriefing. I was able to utilize up-to-date technology for both simulation programming and just with the being able to utilize SimMan 3G. Also, I was able to be supportive in the push towards better education on sepsis identification, and able to advocate for the policy and spread knowledge of its presence to new nurses, so that hopefully the healthcare of patients can be improved with earlier identification of sepsis. The standards regarding sepsis identification are current and in keeping with the improvements that are being advocated, not just on our national level, but on an international level. Again, speaking to the Surviving Sepsis Campaign 2012, which again recognizes it's not just a national problem, but an international problem, which again, that campaign sought to actually create a cohesive identification and treatment process for sepsis. I was also able to explore more ways to incorporate simulation into the graduate nurse role, even from the graduate nurse being a learner with maybe simulated learners instead of simulated patients, or just the ability to actually critique and create new simulations, and again, be an all-important member of that team of debriefing and truly moving from lecturing to facilitating learning. When we look at it, the nurse anesthetist students are heavily involved in simulation and have a surgical suite almost within the simulation center that they frequent all the time. I was also afforded numerous opportunities to perform in the role of an educator, creating, programming, facilitating, and collaborating with other simulation educators with a focus of education for the students. When we look at the impact of this project on nursing education and practice, it is felt that it will actually impact and did impact both. It supports utilization of simulation for facilitation of learning, and not just learning, but learning for healthcare professionals and not just students. Improved identification process for sepsis, and that is with the incorporation of things like the code sepsis. It provided helpful code sepsis reminders for the employees. Again, also being able to pass out those badge cards so that they can keep it kind of literally in eyes view, so that it is literally not out of sight, not of mind. And then it is hoped that with improved identification of sepsis, that patient safety may be improved. I hope that you enjoyed my presentation, and these are my references.